It is a beautiful afternoon here in Israel, and I have the pleasure to host a really interesting guest called Iris Shtein. Iris is now in Potomac. She's an Israeli. She worked at Tel Shomer at the Arc Center, but she'll talk about her journey in a second. Iris, welcome to the program.
Thank you, Danny, for having me.
Well, it's my pleasure. And we sort of met on LinkedIn like randomly. It was total randomly, random thing. And then we started talking, and I said, wait a minute, I really love this space. And I want to learn more about what you're doing. And this is an opportunity to tell the world what you're doing at Mentally. So let's start with the first question, which is tell us about your journey, how you ended up in Potomac from Israel, right?
At Washington, yeah. So actually, I can say that my journey started early age when I was a professional gymnast, an Olympic gymnast. And from early on, I was determined, competitive, and overachiever. I think those are great foundations for a CEO and a founder. As a,
That's
as
for sure. You have to be an overachiever and competitive, right?
Yes, so I served in the army in the IDF for 11 years as a medical officer. When I finished my service, I wanted to come to the best place in Israel in terms of medicine. So, of course, I started my job at Sheba Medical Center, which is the top tier of the hospitals in Israel and, of course, in the world. And I was actually one of the first employees at ARC Innovations when this initiative of innovation just started. And I had the pleasure to grow with it. So at Shiva Medical Center, I was leading the telemedicine, the remote care hub during the time of COVID, when people were in lockdown, struggling with depression, anxiety. And one of the things that we used to do were trying to see how we can harvest the technology and create a real impact and solution. So I think that that was the first time where mental health became a huge issue and a huge and take a huge part of our attention. But unfortunately, at that point, the technology wasn't quite there yet. And it waited and waited until, unfortunately, the geopolitical situation in Israel. When October 7th happened, I knew that we will have a tsunami of people that will need mental support. And unfortunately, as someone who works at a hospital, at a medical system, I knew we just don't have enough manpower, psychiatrists, social workers, psychologists to provide the care that was so needed. At that point, I was working mainly with corporates and public companies, creating value to the hospital and to the health system. So I reached out to one of my portfolio companies, which was Microsoft at that point, and I offered them to join us in this mission to create a platform that will transform the way we access to mental health care. And this is exactly what we did. Together with Shiva Medical Center, Arc Innovations, and Microsoft, we started to develop this platform as a clinical decision support system that allows us to provide care to up to 5 times more patients with the same manpower. So this is, in a short notch, how everything is started. The ability to see an opportunity, to combine the dots, and to create something from inside the system, inside of the real pain that actually scaled into a startup company. When we initiated this project, it's not like we thought about creating the best startup or moving to Washington and working now with the US military as we do today. It was a real solution for a real pain that can be done together as fast as possible by joint collaboration and a huge determination.
That's an incredible story. And it's a story which I think needs to be told. So tell our listeners a bit more exactly what Mentally does.
Yeah, I would love that. So there is a huge need, as I mentioned. A lot of people want to meet psychiatrists or professional in the mental field needs to, but unfortunately there is a huge gap between the supply and the demand, the amount of people who need to be treated and the amount of available clinicians. This is exactly why we developed our model. We call our model Live. Live is an AI-based avatar that actually conducts a full psychiatric assessment, just like real psychiatrists would probably do, anytime, anywhere, from your smartphone or from your computer, from your tablet. You can click on a link and meet Live. Live will assess anyone, anywhere, just like real psychiatrists. After the assessment, the model generates a full summary. This summary is being provided to the organization. Now they know what is the urgency, what is the diagnosis, what is the differential diagnosis, what are the symptoms, who need to meet psychiatrist tomorrow, and who need to meet social worker in 3 weeks. The ability to triage and manage the manpower much, much smarter and better. It is a clinical decision support system. It's not replacing the clinicians, which means this individual will meet a human. But when will meet the clinician already have in their computer their diagnosis, their symptoms, their medical history, their differential diagnosis, their recommendations, everything that they need even before the patient step into the office. So instead of having now an hour intake or an hour and a half session, now it takes 20 or 30 minutes and actually allows our clinician to provide much more efficient treatment, much more personalized, because they actually know exactly what's going on. They're not occupied about documentation because they have everything in their computer, and they're actually providing the human touch and the empathy without being occupied about the documentation or the things that the AI already did for them. So we're actually helping our clinician by empowering them and helping them to do their work much, much better. And another thing that it's very important to emphasize, you can use Live simultaneously, anywhere, any place, millions of people at once. And with every session, Lives become much more smarter and much more capable, which means with any session, we actually improving our model and helping our patient to get the best access that is possible, no matter the language, no matter where they are. It's a huge, huge transformation in terms of health equity.
That's incredible. So it's basically what you're saying. So it's the patient, potential patient can sign up, and then the clinician can then basically see the intake from the interaction with Leaf, and then come very prepared to the first engagement with the patient. Did I say that right?
Yes, and even before that, which kind of the patient? What is the urgency? Does this individual need to meet psychiatrist or maybe someone else? And again, the organization already have some kind of prioritization, red, orange, yellow, green, the ability to triage those huge populations simultaneously much, much better. What we're actually deploying is 4 different methods. First is screening. In huge population, who needs what? Second, triage, the ability to assess the risk and the urgency. 3, full psychiatric evaluation and intake. And 4th, assessment between sessions. We develop the ability to remember and to compare between sessions so we can detect deterioration even between sessions as well.
Or improvement. Maybe the patient's getting better, right?
So we actually conducted 2 clinical trials and we compared our model to real psychiatrists. An individual was assessed by the model and then was assessed by a psychiatrist or vice versa. And can you guess the results?
And what's the answer? Or you can't say that.
No, I can. It will be published very soon. I will say that the results were remarkable. We were able to assess in over 90% accuracy. So if we compare our model to real psychiatrists, 90% of the time the model and the psychiatrist will agree. But if you compare 2 psychiatrists, the accuracy between them will be around 60, 70%. Our model is objective. Our model is based on the DSM-5, which is the Bible in the world of psychiatry. And no matter what, no matter who sits in front of them, we will always get the same results. We're providing something that is stable, with explainability, without any hallucinations, because this is our own models that we created, and consistency, of course. And this is actually why we received the first ever AMAL, which is the Israeli FDA approval for medical device in the world of AI and mental health care. So we are very proud of it.
Whoa, that's an accomplishment, all right. Um, so I'm beginning to get a really good sense of the value, but I want to hear it from you. So the next question is value creation. So you've talked about how you can make the engagement with the patient more effective. You talked about how you can maybe smooth out the differences. Um, so first of all, who's your customer?
Great question. So in Israel, we mainly work with B2G, with government organizations, with large health organizations, with huge scale of patients and populations, specifically underserved population, trauma-related patients, and other kind of complex situations that actually demand a fast assessment. In the US, we work with two huge buckets of population. First of all, is first responders. And one of the studies that we conducted in Israel was specifically on first responders. So in the reason why I'm here in Washington is because we are working with the US military. We work with Walter Reed, which is one of the biggest military hospitals in the US, with the Henry Jackson Foundation, one of the organizations that promote or NGOs that promote innovations in the Army and was funded by the Congress. So this is one of the huge population or of our partners. And the second one, in terms of general population, we work with IDNs, with FQHCs, with providers, also for general population. I would share another thing that it wasn't been published yet, but specifically when I share the fact that in Israel we work with underserved population, we also work with teenagers and children to assess trauma.
That's a big thing right now because that's, as you know very well, I think as we all know very well, after COVID, trauma with teenagers like has just rocketed, just skyrocketed. It's gone up really, really fast. So you're, so you sort of like, when you're an investor, they always ask this question, why now? The why now question, the answer to the why now question is right there in front of us, right?
Yes, yes, but again, like we tackle a very sensitive areas, and I think that this is make us unique. The ability to work so closely with the military, with the first responders, with the policemen, actually made us an experts in terms of PTSD and in terms of suicidality, self-harm, harming someone else, specifically among first responders, because there is a big difference between this population in comparison to the general population. We see a lot, much more like substance abuse. We see much higher percent of suicidality related to PTSD or comorbidity between PTSD and depression or PTSD and anxiety, which is secondary. Our model not just provides one diagnosis, our model can assess comorbidity and subdiagnosis and symptoms and things that are much more complicated to be diagnosed, sometimes even by a human.
So I guess, when I hear PTSD and Walter Reed, the first thing that comes to my mind is that you're dealing with people who served in the military. Is that correct?
Yes, with first responders, you're correct.
So this is this is a service which you provide to first responders themselves because the first responders may be suffering from PTSD.
So you're correct. What we are doing, we're actually in process of deploying our model. So it will be the golden standard for assessing PTSD in the US Army.
Well,
So
uh,
just think about how this initiative was born from our own challenge and our own pain and understanding that we will need a tool that will assess this population. And now the knowledge, the expertise, the data that we were able to reach out to in Israel is now actually helping us to scale and implement and help US first responders as well, which is a huge, huge pride of us. In a very, very short time, we were able to accomplish it. And
well,
I think, Danny, that this is what makes it special because in our field in healthcare, It's always about impact. And when you see those underserved populations, those populations who are usually falling between the cracks, now being seen, it makes all the difference. My team is like a suicidal squad because they know that what they're doing actually matters. And when they're succeeding, they're actually helping in no time a huge population of people. This is why we're so proud of what we're doing and in our accomplishments.
Well, I can see by the smile, it's tremendously satisfying. Um, so, so tell me, I guess this is sort of like a business question. It's like like a VC kind of question, but what's your moat? What's your superpower?
So I think, first of all, we're not trying to replace the clinician. It's not about replacing the psychiatrist. It's about enhancing them. It's about empowering them and about helping them to be the super psychiatrists or the super social workers that they can be as a clinical decision support system. The second thing, it's not a wellness app. It's not an administrative app. We're actually touching the core need of the clinicians as by providing diagnosis. If you see the other ones, the competitors, they're not going so far. They're more like in the administrative or the wellness. Um, so this is another thing. And the third thing, I think the fact that um, it was born, this initiative, in a very specific period of time. Our spirit is that we don't have any other choice but succeeding, and we will be the first and the best because we don't have any other choice. And maybe the fourth thing, and it's not really related just to specific this field, but overall, unfortunately, in our field, we're not seeing enough women co-founders, enough women CEOs. I am proud to share that 70% of my companies are women, and we making a mark on this field as well. Because if we are providing health equity, it should be health equity all over across
For
the
everyone, right?
exactly. And this is exactly what we're promoting: equity inside and out.
Well, I have to say that you're sort of like in Hebrew you say you're kicking down an open door. But this is a topic, this is a theme which recurs throughout the podcast. And we had on the show a few weeks ago, we had Kim Barecki, who is the CEO of Veristat, was a big CRO. And the reason why we wanted Kim on the show was because it turns out that in an industry, clinical trials industry, which is basically like dominated by women, most of the executives are
Men.
men. Exactly. Not only men, but sort of like older men, in suits, right? So I won't say more than that. Anyhow, so otherwise I get in trouble. So having Kim on the show is tremendously interesting. I'll share the link with you. I think you might enjoy the show with her.
I would
And
love that.
and you're part of my own personal crusade to help bring attention to women who are starting things, driving things forward like you. And that's for me, that's a pleasure and a privilege. Um, I guess it's a really interesting space because you said that there are a lot of wellness apps out there, but you guys have actually gotten into the core of screening and triaging, first responders before they get to see a clinician, which is really an important place to be. So tell me, what are three things you want to do for you? So your customers are, I guess right now you're working with Walter Reed. So your customers are like, um,
We do have to, let's say,
hospitals. You
yes,
work
as
with,
well. Yes.
right.
So there are two buckets. There is the world of first responders as a very specific world and a very specific path. And there is another one, which is the FQHCs, the IDNs, the providers, the hospitals, more for general population. So we work in those two fields with different kind of products. We've created a very modular, flexible platform, which means we can adjust it pretty quickly to any client. So we are very, very focusing now on scaling in the US. This is why me and some of the team already here in the US physically to create this scale and this deployment on across large health organization and systems in the US, both civilian and military. Also, we are working very, very hard on making our platform the best and smartest and most intelligent platform that is available right now in our field. It's not just a feature, it's a whole platform. And also one of the things that, as I said, we are very focused on helping those underserved populations, no matter who they are. This is our agenda. This is we believe, our strength to help them to get the access to mental health that they need. And it is done now by using this model.
It's a great model, and I love it because it addresses the front end, which is always kind of a blocker to getting anything done, you know. So what's the business model? How do you capture value? You create a lot of value, but how do you capture value from the system that you're developing?
Of course. So it is a SaaS system, which means our clients pay us monthly for the licensing, but also they're buying packages. In terms of what we're offering, we're actually offering value-based care, but also fee for service. We're helping our customers to meet much more volume of patient. Instead of meeting just one patient, now they actually can meet in the same time 3, 4 patients, which means they can reimburse 3 or 4 times more in terms of fee for service. On the other hand, in terms of value-based care, and this is more relevant for like IDNs, we help for early diagnosis, which means we prevent hospitalization and we help those organizations to make sure that their patient having better outcomes. So in terms of value-based care, this is the perfect match. This is why we can work with those variety of organizations, FQHCs, IDNs, the VA, the providers, and because of this flexibility to provide value in those fields.
So is it a pure SaaS? You don't have to go into numbers, but is it a
Yeah.
pure SaaS model, or is it like you have kind of like a revenue share thing where you get some more money the more value you create? I don't know how you measure that even,
So
but
currently it's mainly SaaS. So our clients pay us based on SaaS models.
what number of clinicians using the system?
Licensing fee packages, usually our clients buying packages of usage, packages of intakes, packages of different services that we are providing, and they paying us monthly.
Okay, so it's a well known, well proven business model in the SaaS industry, and even though everyone is saying that AI is killing SaaS, I don't believe so. I think that AI is creating new opportunities for SaaS. And just you're a perfect example of all the people that somebody said, well, AI is killing SaaS. I said, well, look at Mentaily. You know, that's an opportunity that didn't exist before AI.
Definitely, I think that like with time we will go much more to value-based care because this is a trajectory of the market and we can adjust it. But this is the beauty of it. We are a agile enough, flexible enough, and can play on both fields. This is why this is really the perfect platform for this timing, because even with the transition, we understand specifically how we create value.
And you're Israeli, which means that you move a lot faster than a lot of other people, right?
And that we don't have any patient, and we want things done fast. Yes, I think that being Israeli is definitely can be challenging, especially now, but also it has his charm.
It does have its charm. Yeah, I like that. I
Yeah.
like the way you put that. So we're getting up to the surprise question. And I started asking surprise question about 3 or 4 months ago. And so here's the surprise question. What is the biggest anti-pattern in your industry today?
I think we covered it. I think the ability to not replace the clinicians, but help them and enhance them. It's not like AI going to replace the clinicians. Clinicians that not using AI will be replaced by clinicians that does use AI. So I think this is like the biggest like anti-pattern in our field.
So in other words, the people that come and say that AI will replace doctors, that's not going to happen.
No, I don't believe it. It won't, it's not something that we will see in our lifetime.
It's funny you said that because my no, of course, this is not mental health. This is primary care. So my primary care physician in Clalit and at home told me a few months ago. She said I fully expect to be replaced by an AI in a few years. So I said I don't know. You it's hard to it's hard to see how an AI could replace you.
I
Um,
I believe that especially in mental health, the human touch is is I don't want to say mandatory, but is crucial for succeeding to reaching out. No matter how the AI will be accurate and right and efficient, there is something about us human, the human touch, the look, the touch, the
the
empathy,
smile,
the
the
smile,
empathy.
the something that we needed. And I think that with time, by being more and more depending on the AI from one hand, we will need the human touch even more from the other hand. And in the mental health care, when people are in crisis and need emotional help, they will still need the human touch and the human clinicians. But we need them to be able to provide much more care in much higher scale. And this is exactly how our model, how Live will help them to accomplish it.
So maybe, I'm listening to you and I been thinking about this for several months now, talking to guests on the show, that maybe, we're looking at this in the wrong lens. In other words, maybe instead of looking at it as through an operational lens, which is the US healthcare kind of way of looking at things, which, how much time can we save? How faster can we go? How much, more can we get done in a short visit? It seems to me that if we shift the focus to patients, okay, and look at the lens of patients, and we said, how can we make the interaction with the patient much richer and better when they come and talk to the doctor? Because several physicians have told me, actually, almost every physician I speak to say the same thing. They said this whole thing about having 8 minutes to talk to a patient, which is, I don't know how it works in the US. I think in Israel it's 8 minutes, is like, every physician will tell you the same thing. I don't need 8 minutes. I need 40 minutes. But being able to come into that meeting with the physician and really have a much richer engagement because the physician and the patient have used your system to deepen their understanding of what could be done. Is that a better way of framing it, perhaps?
I think so. And even before that, who is the clinician? What kind of clinician you need? Sometimes we wait so long to meet the clinician, but it's not the right clinician. We spend time by waiting and scheduling and going and driving, but you know what? Maybe it's just a waste of time. And there is someone else that can be much more beneficial to our needs. And this is exactly what we're doing. It's the real personalized care. Because even before wasting my time by seeing someone or waiting for someone, our model can know exactly what each one needs, each individual, and able to help them to access it as fast as possible.
So I would sort of push back on that. I would say that if I was selling the system, I would say to you, if you were my customer, I would say, don't think about how much time you can save, but think how much you can enrich the interaction with the patient. And when you enrich the interaction with the patient, then you can get so much more done. You can be so much more there for the patient.
And you're totally right, but also the administrative time, it takes time. And like there is a whole process that's being done behind the scenes, even before the clinician get to meet the patient.
Oh yeah. Oh yeah.
And by again using this model from home, anywhere, any place, any language is possible. Like think about the opportunities that now are available to those individuals. So this is the real transformation. And this is why we treasure the health equity, because by using AI in the world of mental health care, even before seeing the clinician, it is a transformation, and it will allow anyone, no matter who, what their need, what are the pains are, to get what they specifically need before even meeting the clinicians. They will meet the clinician, but the right clinician that will actually can help them.
So it's access, it's utilization, but I'm going to say I still think it's a lot about enriching the encounter between the patient.
Definitely. I won't argue with this. Of course, you're right, but I want to emphasize that it's bigger. It's big. It's much more than just this.
Yes, it is. Well, so I guess you guys are in the right place at the right time. This question about why now, it's a slam dunk, why now? Um, and Wow. I'm going to just recap this. My name is Danny Lieberman. I'm the host of Life Sciences Today. I've had the pleasure and privilege of hosting Iris Shtein, who is the CEO and co-founder of, did I say this Mentally or Mentaily?
So it's like you say Iris or Iris. So it can be in Hebrew Mentaily, in English Mentaily, but it's Mentaily.
It's Mentaily. So it's Mentaily and it's Iris Shtein. In American Israel, you would say Iris, right?
Right.
And calling in from beautiful Columbia, Maryland. I haven't been there for a while, but it's a wonderful area.
Yeah.
Iris, thanks so much for being my guest on the show.
Thank you so much, Danny, for inviting me. It was such a fun.